there. All right, everyone should be able to hear us on Zoom, and just trying to see how many people we had on Zoom, but I can't see that right now. Thank you everyone for coming. And of course, thank you to everyone who's on Zoom attending this. I know sometimes it's difficult to make it into the city, especially now with this crazy traffic on the Kennedy and all the traffic that's created. But I know how big of an interest this is. I got this massive list of questions that we're supposed to try and answer tonight, of which I think a number of them we will be able to touch on. In any event, welcome to the inaugural, as I'm calling it, town hall meeting on eosinophilic gastrointestinal disorders here at Northwestern and Lurie Children's. I'm Dr. Josh Wechsler. I'm a pediatric gastroenterologist at Lurie Children's, and I'm the medical director of the eosinophilic gastrointestinal disorders clinic. I'm personally very blessed to be able to spend virtually all of my time taking care of patients and researching eosinophilic GI disorders. And I'm excited today to moderate this meeting in which we'll highlight physicians and dietitians that care for patients with EoE. Each speaker will discuss a topic with time for questions that they are an expert on. And we're really blessed to have a panel of truly all experts in the field with which we're talking about a variety of things on EoE tonight. Just a few housekeeping rules for everybody. The goal of a town hall is really is for engagement. So of course, questions are absolutely welcome, and I'll do my best to facilitate questions via Zoom. But I think, in the interest of not interrupting the speaker, just try to ask that once we hit the Q&A period for each speaker. And then just to limit a few specific types of questions, because those are very difficult to talk about. So questions on specific patients, those are not the kind of questions that we're going to be able to answer in a setting like this. Definitely something you want to talk to your doctor about. And then I think questions on FDA timelines for drug approval, because that's definitely not something that we have advanced knowledge of, and I'll let you know all that right now. So as much as you want to know, we want to know too, and we don't know those answers. So definitely there's not going to be much that we can offer there. So with that, I'm delighted to introduce our first speaker, Dr. Nirmala Gonsalves. She's going to speak to us about the current diagnostic criteria and breakdown of eosinophilic gastrointestinal disorders. I think before I do that, let me just go ahead and quickly introduce all of our panel here. So if you all could just grab the mic and just say a few words about yourself. Dr. Gonsalves, we can start with you.
Hi, everyone. I'm Dr. Nirmala Gonsalves. I'm an adult gastroenterologist at Northwestern here, and I co-direct the eosinophilic GI disorders program. Thanks.
Hi, everyone. My name is Natalie Hoffmann, and I'm a pediatric gastroenterologist. I work in the eosinophilic gastrointestinal disorder program here at Lurie.
John Fortunato. I'm a pediatric gastroenterologist at Lurie as well, and I run the motility program for pediatrics.
Hi, I'm Fei Kuang. I'm an adult allergist at Northwestern University across the street. And I have a clinical and research interest in eosinophilic disorders, including EGIDs.
Hi, I'm Sai, the allergy guy, or Dr. Nimmagadda. I work at Lurie Children's Hospital, a pediatric allergist for the last 30 years, and also at CFAAR as the chief allergist over there at that center. Been in this space for 30 years, and I've learned a lot through the years looking at asthma and also comparing it with EoE.
And then if you could just pass it back to Dr. Wershil. Appreciate it.
Hi, I'm Barry Wershil. I'm the chief of the division of pediatric gastroenterology, hepatology, and nutrition at Lurie Children's, and have been lucky enough to recruit some of these people to do this work. A pleasure to be here tonight.
Okay, definitely want to say thank you to our official sponsors as well. A little bit about Elodie that you can read here. Now recruiting for the Flute 3 trial. As I mentioned, our speakers, we also have a couple of speakers today joining us virtually, our dietitians, Bethany Doerfler and Sally Schwartz. Bethany, could you introduce yourself if you're there? Okay, I don't know if we have Bethany on yet. Sally, if you're there, do you want to say hi real quick? I don't know if people are having trouble unmuting themselves. Got it. I don't know if we can assist people in getting into the Zoom. That would be helpful. Okay, we'll move forward. So you can see today's topics here, the current diagnostic criteria and breakdown of eosinophilic gastrointestinal disorders, assessing and treating scar tissue, current treatment options for EoE, the role of the allergist in allergy testing, whether EoE might be misnamed, Ehlers-Danlos syndrome and POTS, how do we screen for these? And certainly a host of questions regarding diet elimination and Dupixent will be part of our panels. And with that, we will turn to our first speaker. There we go. We've got our 39 participants online. So I don't know if anyone can help with getting the others in while I switch the slides here. Perfect. All right. So now officially, Dr. Nirmala Gonsalves, Professor of Medicine, Co-Director of the Northwestern Eosinophilic Disorders Program. I am, of course, as always, delighted to hear you speak about EGIDs.
All right, thank you very much. Thank you for the invitation today. My topic is to review with you EGID nomenclature, characterizing eosinophilic gastrointestinal diseases. Here are my disclosures. We won't be discussing therapy at all. So what I am trying to do in this next 10 minutes is to review with you the revised nomenclature for non-EoE EGIDs, as a lot has changed. We'll highlight some clinical manifestations of location-specific disease, and then I'll review with you where we're at for developing diagnostic criteria for non-EoE EGIDs. So before we get started, I just wanted to review a little bit of the anatomy of the GI tract and things that we refer to in endoscopy reports that you read. So here we have our esophagus. We then go into the stomach. This is the cardia, the fundus, the body, and the antrum. Then go into the duodenum, the jejunum, the ileum, and then here's your colon, starting off at the cecum, the ascending colon, transverse, descending, sigmoid, and rectum. So if you see your pathology reports and then your endoscopy reports, that's what it's referring to. So where were we at with non-EoE nomenclature? This is version 1.0, so to speak. So eosinophilic esophagitis, or EoE, was eosinophils located in the esophagus. If it was located in the stomach, it was called eosinophilic gastritis, and at that time, the acronym was EG. If it involved the stomach and the small intestine, it was previously called eosinophilic gastroenteritis, or EGE, and located in the colon, eosinophilic colitis, or EC. But there was a lot of controversy with the term eosinophilic gastroenteritis. And this questionnaire really highlighted that controversy because people were using eosinophilic gastroenteritis in various different ways. And so as experts in the field, we actually asked clinicians, when they use the term eosinophilic gastroenteritis, I mean to indicate that disease involves what? And you can see here across the board, there are a ton of different answers. Many people answered correctly, meaning involving the stomach and small bowel, but there were so many different answers that came up. And that really highlighted heterogeneity in this terminology. And that led to variability in the clinical use of that term and the medical literature. That led to imprecision both in clinical practice and in research, and it really highlighted the need for standardized terminology to move the field forward. So that's exactly what happened. So what you can see here is there was an international consensus guideline that came out about EGID nomenclature. And this was comprised of 85 different participants from across the globe. It was really a multidisciplinary group from adult gastroenterologists and pediatric gastroenterologists, allergists, researchers, pathologists. Really every key stakeholder came together and tried to agree on this nomenclature. And if you can imagine, like just our panel up here agreeing on something, trying to get 85 different experts in the field to agree on something was quite daunting, but it actually did occur. So I'm going to show you in the next slide what the new nomenclature looks like. and I think this is kind of cutting off the top, but essentially, I hope folks up, I don't know, can you move this panel, Josh, or no?
You should just be able to click on this.
No. Okay, it's okay. So basically, the overall disease category up here is called EGID, or eosinophilic GI disease. Do you have a special
Yeah.
way to get rid of that?
Move it. Is that better?
Sure.
Okay.
Yeah, my kids will tell you I am not the most technologically savvy individual, so they tend to, deal with all my social media and these sorts of things. Okay. So essentially, the overall disease category is eosinophilic gastrointestinal disease, or EGID. So that's a whole umbrella term here. If eosinophils are isolated to the esophagus, it's called eosinophilic esophagitis, or EoE. That's not going to change. That's going to remain the same. Nothing is going to change here. But any other location is going to be referred to as non-EoE EGID. If eosinophils are isolated to the stomach, it will be called eosinophilic gastritis, or EOG, to mirror the EoE. Isolated to the small bowel will be eosinophilic enteritis, or EON, and isolated to the colon, eosinophilic colitis, or EOC. And if you know the specific organ location, for instance, eosinophilic duodenitis, jejunitis, or ileitis, it will be broken down even further like that. Now, if there are multiple areas involved, for instance, eosinophilic gastritis and enteritis, the recommendation is to be very specific, calling it eosinophilic gastritis and eosinophilic duodenitis, or eosinophilic gastritis and enteritis. You can still use the term eosinophilic gastroenteritis, but really focusing and using that only if it involves the stomach and the small intestine. So again, the updated nomenclature looks like this. Again, EoE is going to stay the same. Eosinophilic gastritis, EOG, eosinophilic enteritis, EON, and then eosinophilic colitis, EOC. Now, for the multiple regional involvement, looking at this a little pictorially, here, if you have involvement in your esophagus and stomach, the preferred term is going to be eosinophilic gastritis with esophageal involvement. You can still use the term EoE and EOG, but keep in mind the definition of EoE is disease isolated to the esophagus. If it's involving the stomach and the intestine, the preferred term is eosinophilic gastritis with enteritis. And eosinophilic colitis will remain the same. So that's the characterization based on the organ involved. It's also important to know that there is a characterization based on the layer of the digestive tract wall. So if you think about the digestive tract as being a donut, so to speak, the inner portion of the donut is the mucosa, the deeper portion, the muscle layer, and then the outermost portion, the serosa. So EGIDs can be classified as mucosal, involving the innermost donut, muscular, involving the deeper layers, and serosal, involving that outermost layer of the gut. So how does that play into the clinical manifestations of these disorders? It's important to know that symptoms really vary by organ involvement. So in patients who have eosinophilic gastritis, most common symptoms include abdominal pain, nausea, vomiting, early satiety, meaning feeling full more quickly, or diarrhea. On lab work, you can see a low hemoglobin or anemia, high eosinophils in the blood, a low protein level in the blood, or low iron. If you were to get an imaging scan with a CAT scan or an upper GI series, you may see gastric thickening or pyloric stenosis, and atopy, meaning other allergic disorders, are often present in this condition. With eosinophilic enteritis, meaning involving the intestine, you have similar symptoms, but you may see more diarrhea and more bloating the more small intestine is involved, and when patients have what's called protein losing enteropathy. In that circumstance, you can have low protein and low iron, even more profound than the gastritis picture. Imaging can show small bowel thickening or strictures, and atopy is typically present. And eosinophilic colitis is a little different. You might have more diarrhea and rectal bleeding. This is by far the most rare form of these disorders. You can see anemia and eosinophils in the blood. Imaging can show colon thickening, and atopy is not as common as the other disorders. Now, everything I've talked to you about highlights the presentation of the mucosal disease, that innermost inflammation of the donut. But symptoms can also vary by tissue layer involvement. So if you were to have kind of deeper layers of that donut in terms of the muscular variant, you can have wall thickening of that gut, impaired motility, and a rigid gut that can result in symptoms of intestinal obstruction. Patients can have nausea, vomiting, abdominal distension. And serosal variant is the least common type. That's when people can have ascites or water in the abdominal cavity. You can have ascites in combination with that mucosal and muscular disease. And the hallmark is if you were to sample that belly water, there's a high number of eosinophils in the ascites. Histologic criteria, we won't dive into too deeply other than to say in EoE, over 15 eosinophils per high-powered field has been the mainstay. The question is, what is abnormal in the rest of the gut? In the esophagus, it's pretty easy. There are normally no eosinophils in the esophagus, but there are normal numbers of eosinophils in the rest of the gut. So how many eosinophils are too many in these circumstances? This is an area that's actively being developed, but currently the thought process and the guidance is more than 30 eosinophils per high-powered field in the stomach. In the small intestine, an option of either over 30 eosinophils per high-powered field in 3 high-powered fields or more than 52 eosinophils. And when I'm referencing a high-powered field, that just is an area on that slide that the pathologist is looking at and counting those numbers of eosinophils. And the colon has a varied number throughout the right colon, transverse, and rectosigmoid. Again, this is an area in evolution, and these numbers may change just a bit. In terms of endoscopic features, what types of things do we see on endoscopy when we do procedures on patients with eosinophilic gastritis? These are just some examples. This is based on an EG-REF score, which was developed by Dr. Horano and the Seeger group, Eosinophilic Gastritis Endoscopic Reference System. These are the features here: erosions and ulcerations, granularity, raised lesions and nodules, erythema, thickened folds, friability, and pyloric stenosis. These are just some pictures that show this. So these erosions are these little scratches all through that mucosa, the lining of the stomach. There can be some superficial ulcerations, so these deeper scratches, bigger ulcers seen here, and pretty deep ulcers all the way over to that right panel. Raised lesions can be pretty mild here, just a little bit of lumpy, bumpy, to much more prominent, almost a pseudo polyp-like picture here. Normally the stomach is smooth and glistening. And granularity is either absent, fine, or coarse. And when we see these findings, it begs us to take biopsies. And the question often becomes how many biopsies to take. And Dr. Wechsler wanted me to highlight this. Now, eosinophilic esophagitis, we know that the disease is really patchy. And there's been great work done from Northwestern and Lori highlighting that you need at least 5 to 6 biopsies to make the diagnosis of EoE. So how many do we need in EOG or EOD? So this is a nice study by the lirentelimab study showing that increasing the number of gastric biopsies and increasing the numbers of biopsies in the duodenum increases that yield, helps make this diagnosis. So we advise taking a minimum of 8 gastric, meaning stomach biopsies, and a minimum of 4 biopsies in the duodenum to make this diagnosis.
record for a second, just a minute.
Oh, okay. Okay. So here is what we're thinking about. This is in evolution. This is not finalized by any means, but we have a large working group with the SAGR group to develop these diagnostic criteria, which will hopefully be done in the next year. But we know that there is an importance of including symptoms as well as that eosinophilic inflammation, just like EoE. Chronicity is going to be very important. This is not a one time you have a symptom and you have this diagnosis. Having these symptoms over a long period of time is really going to make that diagnosis. Histology, we may hear about a little bit later, but in addition to eosinophils, there are other features that will help support this. Endoscopic features will help support the diagnosis. And there are numerous other things here that can be supportive of the diagnosis. So this is a work in progress, and hopefully we'll have more to share soon. So in conclusion, revised nomenclature for EGID provides more precise terminology that specifies the affected region of the GI tract. And current diagnostic criteria for EGIDs are evolving to include more specific characterization of non-EoE EGID. And increasing research has identified many fundamental similarities between EoE, EOG, and EON. Lastly, I would like to thank many familiar faces in the audience and who are online, because you all truly are the reason why we do what we do every day. So thank you to all of our patients.
Okay, Demi, thank you so much for that wonderful talk. If there are any questions, we can take probably one or two. And I don't see Ellen, go for it.
They want to talk to their physician who's doing. Where do people go when they are going to their GI and they're going to take biopsies, and the doctor wants to take one biopsy of their esophagus and maybe two from the stomach or none from the stomach? Where do they go to print up information to find the amount of biopsies that should be taken? It doesn't go over well when they say my patient advocate told me to do this. It would be better if we can send them to a site that showed this information.
Yeah, great question, Ellen. These guidelines have been folded into, or these recommendations have been folded into multiple recent guidelines. So the ACG EoE guidelines are out in 2013. There's going to be another revision in the next year. The recent ASGE guidelines came out this year in 2023, which do highlight taking at least 5 to 6 biopsies in that esophagus. And the reference that I had by Dellen and colleagues is the one for the non-EoE EGID. As part of clinical practice at Northwestern, we do a minimum of 6 duodenal biopsies, similar to a celiac protocol, as well as 6 to 8 biopsies in the stomach, targeting the areas of abnormal mucosa. But those references are things that the patients can use.
So there's a nice question here in the chat. And it was actually basically the same question I really wanted to ask as well. So I always learned EoE, it's a condition isolated to the esophagus, but then we oftentimes find that there's patients that have inflammation in the stomach. We don't know which is primary, which is secondary, but now we have a drug that we can give for EoE. But if we're saying that it's a disease isolated to the stomach, is it a problem if if I'm seeing a patient and they have evidence of EoE and the evidence of EoE, evidence of EOG, that I'm writing, this is EoE, this is also EOG? Am I sort of misquoting the criteria then, this new naming system? You know, what disease do they really have when there is eosinophils in the esophagus, given that's the only disease where there is now an approved drug, and we might want to give that drug because it might even help the other condition as well?
That is a great question. And that was the area that did not have any consensus on that consensus guideline panel with 85 different experts. But because of the definition of EoE always being isolated to that esophagus, so that's where this becomes tricky. But I think clinically, we all see patients who have, documented EoE who also have these profound gastric and duodenal abnormalities. I would say in that circumstance, it seems very reasonable and in my clinical practice to to, use a medication that targets their EoE and may have some benefit on the rest of the gut.
Okay, and now here's another question that we received ahead of time that I thought was absolutely fascinating in the sense that I was trying to think, what would I say too? So I want you to take the perspective of an adult patient when you answer this question. I was just diagnosed with EoE. What are the first 3 things I should do?
Well, that's very broad.
No, that's a tough one because I couldn't, at least give me the first 2. How about that?
Okay.
Not an easy one, I know.
Not an easy one. I mean, I think if you were, if I was just diagnosed with EoE, I would ask my clinician, please describe to me what my esophagus looks like. Please describe to me, how wide that esophagus is. If I have strictures, I'd like to understand the inflammation burden that I have, as well as the stricturing burden, to try and understand how that all explains my symptoms, assuming my symptoms are pretty classic and I have difficulty swallowing. And then I would ask the clinician, tell me about the different treatment options, please, tell me about the pros and cons between these treatment options. And that's how I approach things with our patients. We will talk about pros and cons of each different option and then make a joint decision together. So I would try to do that.
So one thing you didn't say that I think, is a challenge for us as doctors that oftentimes see 2nd, 3rd, 4th, 12th opinions, whatever it is. How important is it in the initial phase of being diagnosed with an EGID, and maybe a specific type of EGID matters? Is it to find an EGID specialist, someone that really is up to date on the procedures and the literature and the treatments and things like that?
So that's a very loaded question because I think all of us are incredibly biased up here that you should find an EGID specialist. But I think there are many. The nice part about the second part of that question is that every GI society, allergy society, pediatric society has really been highlighting EGIDs and been doing an excellent job at educating clinicians out there. So there are a lot of clinicians that know how to treat this disorder. But if you have the option to find an EGID center, that would be amazing.
So I totally think that what you said is really important. This is an evidence-based medicine type of disease where we have a wide quantity of high quality evidence, both clinical and basic science, that really helps inform what we do as physicians. And so to the extent that you can find those key society papers, and you pointed out the AGREE paper as one really important one, I absolutely think that's important. Okay, time to move forward. Our next speaker is going to talk to us about one of my new favorite topics in the last few years, which is scar tissue. Something I really never appreciated was an issue in kids. I always thought Dr. Gonsalves was really just dealing with all the scar tissue. So Dr. Hoffmann is our newest partner at the eosinophilic gastrointestinal disorders program at Lurie Children's. She's an assistant professor of pediatrics, and I'm delighted to hear about assessing and treating scar tissue in EoE.
Thanks so much, Josh, and it's a pleasure to be here with you all tonight. I'm excited to share this topic with you on something I'm also very interested in, assessing and treating scar tissue in EoE. There we go. Okay, so as we've learned and as most of us know, EoE is a condition that can lead to scarring and fibrosis over time. It's a chronic allergic inflammatory disease of the esophagus that typically starts with a food protein trigger, which leads to esophageal inflammation that involve eosinophils, of course, and other immune cells that contribute to this localized immune response in the esophagus. Now, if this goes untreated or undertreated, that can ultimately lead to scarring or fibrosis. And fibrosis is really the replacement of normal tissue with scar tissue. Now, this in turn can result in stiffness or narrowing of the esophagus, and the esophagus not functioning as well as it normally would. And this can put patients at higher risk for complications, such as food impaction or food getting stuck in the esophagus, which can require emergent endoscopy to remove that food. So why is this important? And why is this, one of the primary areas of focus of our EoE group here at Lurie? Well, the progression of fibrosis and scarring can lead to serious complications. And here are some pictures here of fibrotic rings, which are these circles here that we can see on endoscopy that indicate that there's fibrosis in the tissue. And ultimately, this can lead to narrowing in the esophagus, which is shown here. And these findings can put us at risk of food impaction. Here is a picture of kind of a food that's stuck, that's being removed endoscopically. Now, this previously had been thought of as kind of an adult problem, a result of a lifetime of inflammation in the esophagus from EoE. But we've now found that early signs of fibrosis occur in about 30 to 40% of children with EoE. And this is important because when narrowing or when scarring of the esophagus develops, medications that we use do not work as well to improve symptoms. And when that's the case, oftentimes we're recommending dilation or stretching of the esophagus to provide symptomatic relief. Things like difficulty swallowing, sensation of food getting stuck. So how can we identify scarring earlier to reduce patients' risks of complication? Well, a measurement of scarring that we use is called distensibility, and this is a measurement of stretchiness or stiffness in the esophagus. So as an example, think if you had two cylinders here, and one was stretchy and one was stiff. You stood inside the cylinder and pressed against the walls. So in the stretchy cylinder, it's pretty easy to press against those walls. You can do it when you're drinking a cup of coffee. But in the stiff cylinder, you have to use a lot of strength, okay? It's more rigid. So this stretchy cylinder has increased distensibility. The walls are fairly stretchy. In contrast, the stiff cylinder has decreased distensibility. Now we can measure this in the esophagus with a device called the endoscopic functional luminal imaging probe, or EndoFlip. And this is a device that was developed, pioneered over at Northwestern here, that is used during standard of care endoscopy to measure the distensibility of the esophagus. So what does EndoFlip look like? Well, EndoFlip is a catheter-based tool that goes in the esophagus. It includes these sensors here and a balloon. And the balloon is inflated to distend the esophagus. And what we're able to see during an EndoFlip is these diagonal lines, the orange and yellow diagonal lines here, that represent contractions of the esophagus. And this is a normal response of the esophagus to the volumetric distension of the balloon. We're also able to have a 2D rendering of the esophagus, which gives us measurements of the diameters and ultimately calculates the distensibility or the stretchiness of the wall. And this green arrow here is pointing to the esophagogastric junction, which lies between the stomach and the esophagus. On the EndoFlip, we're able to monitor the volume in the balloon, the pressure in the balloon, and then the diameter of the esophagus to identify and to assess for evidence of fibrosis and evidence that this is affecting the esophageal function. So our group here at Lurie has investigated how the assessment of esophageal distensibility can be used to determine the severity of fibrosis in the esophagus of pediatric patients with eosinophilic esophagitis. And this was recently published in Clinical Gastroenterology and Hepatology. So we assessed patients that were over 9 years old that had symptoms of esophageal dysfunction, and that includes difficulty swallowing, food impactions, or sensation of food getting stuck in the esophagus. And we assessed these patients with both endoscopy and EndoFlip. We correlated the EndoFlip findings to clinical symptoms, endoscopic features, and histologic findings, or findings that we look at under the microscope. And what we found was that esophageal distensibility did predict findings of fibrostenotic severity, or the severity of the fibrosis or the scarring that was seen on endoscopy. And in determining this criteria for a rigid esophagus in pediatric EoE, we looked at things like symptoms of dysphagia or difficulty swallowing, and a history of food impaction. And we found that there was really no difference in the distensibility in patients with the dysphagia symptoms here. But when we looked at patients that had food impaction or sensation of food getting stuck, the distensibility was significantly lower. When we looked at endoscopic findings, we found that patients with features of fibrosis on endoscopy had significantly lower distensibility, as well as the severity of that distensibility was more pronounced when the features of fibrosis were more severe. So we found that the distensibility of the esophagus is reduced, or the esophagus is stiffer in patients with fibrotic rings and a history of food impaction. And we were able to identify specific parameters in pediatric patients, specific numbers of the distensibility that were predictors of fibrostenotic severity or grade 2 rings. And an absolute cutoff for those values. And these findings were really essential in understanding how to objectively monitor fibrosis in pediatric EoE. So who needs EndoFlip? When is this helpful? Well, we did find that patients with difficulty swallowing or sensation of food getting stuck can have lower distensibility or findings of fibrosis. Patients with history of food impaction. Patients with long-standing eosinophilic esophagitis with periods of active disease. And then patients that in the past have had features of fibrosis, namely fibrotic rings or strictures. And really our overall goal is to prevent this trajectory of inflammation to fibrosis by identifying these findings early. And we found that the therapeutic impact of EndoFlip both allows us to identify the location of narrowings in the esophagus, identify the size of the narrowing, and then really helps guide the need for dilation with objective measurements. And this in turn helps improve the safety and the efficacy of esophageal dilation. And over time, we're able to monitor the esophageal function of patients and ultimately their response to treatment with this tool. And here's just an example of an EndoFlip where we did identify a narrowing here, shown in the red circle, the orange piece of the esophagus that is narrowed. This patient did undergo esophageal dilation and ultimately had improvement in symptoms. So let's say, like that last example, we do find a narrowing on the EndoFlip. What is next? What's recommended? So typically in this case, we would be recommending esophageal dilation or stretching to help improve symptoms. Now, there are a few types of esophageal dilation. The first is a through the scope balloon dilation, which is a catheter that is actually put into the endoscope, and it has a rigid balloon on the end, and that's inflated to a desired diameter. There are wire-guided rigid dilators as well, the Savory dilator or a bougie dilator, which also can be put in the esophagus, typically under fluoroscopic guidance. And then lastly, there is a EsoFlip balloon dilation device, which uses the EndoFlip platform with a rigid balloon to stretch the esophagus to a desired diameter, which is able to be monitored here on the EndoFlip platform again, to achieve the desired diameter of the esophagus. Now at Lurie, in our EoE program, we are doing through the scope by balloon dilation as well as the EsoFlip balloon dilation. The rigid dilators are typically used occasionally by our surgical colleagues or interventional radiology colleagues for other indications other than eosinophilic esophagitis. Now, when we're deciding to perform an esophageal dilation, we typically look at both evidence from our patients, data from our patients, as well as data from larger studies that show if this is both a safe thing to do and an effective thing to do. And there is quite a lot of data to show that dilation is consistently effective in both children and adults with EoE. And I included just a couple of studies, but this is an example of over 1,800 dilations, both in children and adults, that demonstrated symptomatic improvement in 95% of their patients. And then a study in exclusively children with 450 dilations that showed symptomatic improvement in 86% of patients. Dilation has also been proven again and again to be safe in both children and adults with EoE. In that same study of children with including 450 dilations, about 15% of their patient cohort had chest pain after the procedure that required reassurance only. And they had 0% of patients with perforation or significant bleeding after the procedure. In a study of over 2,000 dilations in adult patients, less than 0.1% or 1 in 1,000 patients had a complication of a perforation. And then there's even good data to suggest that showed that dilation, the effect of dilation, is long lasting. So the dilation effects of this study lasted longer than 12 months and additionally modified the association between histologic activity, or those findings of active EoE, and the symptom severity. So meaning that even if patients still had active EoE, if they had a dilation, they would still feel better. So we take this all into account when we're determining whether to dilate or to not dilate a patient with a narrowing on an endoflip. And because it has been shown in our patients as well that it's consistently effective and safe, we typically are recommending a dilation if we find a narrowing. Now, just to wrap up, in thinking towards the future of eosinophilic esophagitis and the involvement of identifying early scar tissue and the role of endoflip, I think this tool really allows us to characterize fibrotic remodeling, to identify patients at risk early in the course of their illness. It allows us to treat and stop scarring safely and effectively. And it allows us to establish a treatment plan towards the goal of really tailoring treatment to the individual patient, ultimately working towards a cure. Thank you for your time, and I'd be happy to take any questions.
I actually just have a quick question for Dr. Gonsalves, because I think from our perspective in pediatrics, I really had no idea how significant the scarring was, especially in 8-year-olds and 12-year-olds, that I just really wasn't seeing and knowing where to dilate. How important for you is the endoflip in choosing to dilate versus, you know, something that you tend to do more just in general on patients based on their symptoms?
Yeah, that's a great question, Josh. And I think your surprise mirrors ours, because we also didn't think that children had fibrosis. We thought about this as being more of an adult phenomenon, but we are seeing a lot of strictures. I would say more than 50% of our patients get dilated. In terms of your question about the endoflip, many times we can assess the esophagus and see focal strictures, or we can see a narrow caliber esophagus. And so the endoflip doesn't necessarily help us that much, but particularly in a patient who's having ongoing dysphagia, who we think difficulty swallowing, who we think we've done all our dilations, an endoflip can be helpful to recognize these proximal strictures or even that narrow caliber. The recent ASG guidelines do suggest that dilation should be performed in any patient, any EoE patient who's having ongoing dysphagia, to a targeted diameter of 15 to 17 millimeters. So it's really important to do that. And an endoflip can be very helpful in those circumstances.
So I've heard two things. One is that we should treat the patient and see if they feel better. The other is that if they've got symptoms and there's narrowing, just go ahead and dilate them. We tend to go with the latter. Like if they have any degree of narrowing, just go ahead and dilate them. Is that the general perception in adults as well?
Definitely. I think we used to think about, cooling down that esophagus, getting that treated and then dilating. But I would say in patients who are having lots of dysphagia, food impactions, they really have a critical stricture. I think all the evidence that you just heard from Dr. Hoffmann's talk is that the dilation is safe to do up front. So if we see a critical stricture, irrespective of that inflammation, we will typically dilate.
Fantastic. Okay, we are going to move on to our panel discussion. So Sally and Bethany, if you could unmute your mics, that would be fantastic. So this is just an open discussion. And Sally and Bethany, I really want to give you the first crack at answering this very first question. When it comes to elimination diets, what are my options and what can I eat? And okay, Bethany's saying that she needs help to unmute. Is that something that we can fix?
Okay, success. Thank you.
Okay, Bethany, why don't you start us off with, from your perspective in adults, what in general are the options? I know with kids, we've tend to move a little bit towards less restrictive diets, and I'll have Sally comment on that as well. But what do you see sort of as the kind of the standard in adults? And then what on earth do they do to find food?
Yeah, it's a great question. I think we really like to engage in shared decision making with our patients. I mean, our doctors, Dr. Gonsalves, Serrano, some of our other esophageal specialists really spend a lot of time talking with patients about their options. If you want to pursue food as treatment, these are some of the levels of restriction, as well as sort of the outcomes in adults associated with that. These are some of the medical therapy options. For some of our patients, for example, who say have a kid with food allergies and they say, I'm already restricting A, B, and C, this feels like the right approach to do a food restriction. So we let the patient sort of guide us, but give them the information up front. I think we also try to give people the least amount of restrictions for the most bang for their buck. We do also consider how allergic a person is at baseline. If people have a lot of environmental allergies, they're cross-reacting with a lot of foods, we might consider a slightly, we might suggest a slightly more restrictive diet up front. And the final thing that I'll say about what people eat, this is something I know Sally and I try to spend a lot of time on. These are some breakfast options for you, meal, snack ideas. Here's how you handle social eating. Because I think our patients come in really knowledgeable about, I know I shouldn't eat dairy or I shouldn't eat this or that. But oftentimes it's that impulsive food choice, like where we would have run to grab a sandwich, that people need ideas on. So we really spend a lot of time arming people with ideas, snack recipes, shopping guides, things like that to guide them.
Right. I'd like to take that a little bit further into the pediatric realm as well. Is we always, as dietitians, it's our bread and butter to assess that our clients' nutritional status. Are they malnourished? Are they underweight? Is it a child? Are they growing? Are they following their curve? Are they falling off their curve? If we have an underweight child who is the family's interested in restricting several foods and they're currently not gaining weight, that might not be the best plan unless we have some tools that we can offer them, such as like Bethany had mentioned, giving them ideas on what to have, meal planning, as well as using amino acid-based formulas and multivitamins to help meet those needs. We also need to think about the big picture of the child and the family individually. What is their lifestyle? Are they going from game to game and eating through the drive-through in the car? Is a diet restriction plausible at this time? And if it is so, how can we make it work? So again, those tips and tricks on things to pack. Stealing a little bit from Bethany, she's got her SOS kit, which I like to educate my families on too. Little things that you can grab and go, so you have foods available when the child is hungry after a baseball game or something like that.
Okay, so we kind of touched on this a little bit. Certainly a lot of options and that it really needs to be a customized approach. And I think, Sally, you really touched on this quite a bit, and I want to emphasize this point further. But I want both of you to really briefly touch on really the importance of seeing a dietitian, understanding cross-contamination, and really how the evaluation of micronutrient and calorie deficiency affects what you're ultimately going to recommend.
Well, I think if we were to start with like cross-contamination, just to even the playing field, to define what that is. Maybe not everybody, maybe there's people who are brand new to EoE and are not sure what is cross-contamination. What is this? It's basically cross-contamination happens when one food comes into contact with another food and those proteins mix. I always like to use the burger as an example. So if the child maybe can't have wheat and they order a hamburger and they take the bun off the burger, can they have that burger? And the answer is no, because the cross contact has happened. The burger and the bun have met and those proteins have mixed. And I think that when we talk about cross contamination, there's different levels of it, right? There's eating out, there's at home, and there's ways that we can really make sure that our families are being as safe as possible. Because if you're going through all of the work of trying to remove these foods, if you've been cutting and preparing all of your foods on the same cutting board without washing it in between use, then there's been a lot of cross contact that has happened.
And I guess I would ask a question, in general, because there's a couple of patients ask this, how often can a patient cheat? Can they have a cheat day a month? Can they have a cheat day a week? Maybe once a year on their birthday? Because I have a lot of patients where it's like, I got my scope, we're going to go have a burger with cheeseburger today. So I get that there's a lot of psychosocial aspects that really go into adjusting the diet. What's your perception of cheating? And then I really want Bethany, if you could touch on the flavors of cheating, because what we're finding in pediatrics is there's a subset of kids that seems to be able to cheat more than other kids. Some kids can tolerate baked milk products, cooked milk products. Some kids cannot at all, and they get a little bit of a baked milk product and the disease flares up. I'm curious if you could touch on the cheating, kind of expanding the diet in terms of like baked and cooked products a little bit, Bethany.
Yeah, Sally and I were just talking about this today, so it's perfect timing. I think that in celiac disease, we have a great benchmark for how many parts per million of gluten is sort of enough to really get the immune system revved up. And we don't have that yet in eosinophilic diseases. I would say that clinically, we all see what you've just described, which is that some people can probably get away with a little bit here and there. And I think it sort of depends on what stage you're in. If you're actively doing your elimination phase to determine what your food triggers are, it's really important that we support you in being, as particular as you can be, without making you frantic, because we want to make sure your endoscopy results are easy to interpret. Once you've identified what your triggers are, then it's really a collective decision. At this point, there's no guidelines on, how much is too much and what should we recommend once a week, once a month, a couple of bites versus a whole meal. And what we're hoping for, I think, as a team of for all of us who treat these conditions, are these minimally invasive ways to find eosinophils, because when we do that, we can really get to some of these threshold questions. I will say that in adults too, when our patients are, let's say, going on a trip to France for 2 weeks, rather than putting the pressure on them of trying to stay on their diet or risking that they're not going to feel well, we'll usually, of course, work as a team with our physicians to try to bring medications into the picture to allow them some flexibility on the diet. So lots of important work that I think needs to be done on giving people a very particular and correct answer on that to improve their quality of life while they're on the diet.
Well, one thing I definitely agree with is that when you do diet elimination, you want to be as essentially perfect with it up front as you can be. And that ultimately, when you find that food trigger, I consider it a trial of anything you're changing. A trial could be that I'm going to start going out and going to restaurants, because some patients can't really do that. Or they might do a trial where they might not pay attention to may contain or processed in a facility, but we do it in a controlled fashion. So we try not to do too many changes at once, and we try to make sure that that change is rigorous, what they're doing, and then we get a good answer. Is that the similar approach for what you take in adults as well?
Yeah, I agree. I mean, it's really important to sort of consider all of the variables. I mean, even with people adding new foods into their diet that maybe they didn't do during the elimination phase, but sort of more their maintenance phase, those are things that we like to track in case disease sort of activates again. We want to look at all the food variables.
Fantastic. All right. Well, in the interest of time, we are going to move on to the next topic. Thank you so much to our dietitians for joining us. I know there were probably a ton more questions, and we can certainly do our best to answer them. But I am delighted to I'm delighted to introduce Dr. Barry Wershil, the Division Chief of Pediatric Gastroenterology, Hepatology, and Nutrition at Lurie Children's Hospital, and truly an inspiration to me, because this is how I got into all of this. And so I'm very thankful to be able to introduce him to talk about the treatments of EoE.
All right. Yeah. In the interest of time, I will try to keep this to 10 minutes. And maybe just kind of highlight a little bit of the history of EoE in terms of the therapies that have been kind of established at this point in time, and some of the stumbles and bumbles we did along the way. Just to remind everybody, there are a couple scattered reports in the literature before 1995 about in adults that had profound eosinophilic infiltrates of their esophagus, not really understanding what it was or what it meant. And the real first case report of a group of children with this entity came out of Hopkins in 1995. And not only did it put together a number of children with these findings, but also the fact that they could show improvement when these patients were put on an elemental diet. So the first demonstration of a therapy for EoE came in 1995, and it was also evidence that this was largely a food-related immune response. Today, we have a list of therapeutic options, starting with things like proton pump inhibitors, swallowed steroids, the empiric elimination diets. We heard a little bit about dilation as part of the therapeutic armamentarium for patients with EoE, and now we're kind of moving into the age of biologic agents and agents that are specifically directed at parts of the immune system that are activated during the EoE. You know, we have endpoints of therapy that we're thinking about in our clinics every day, and then there are endpoints of therapy that are demanded by the FDA when we're looking at drugs, and some of these are very difficult to address. In the clinic, we're interested in histologic improvement, the numbers of eosinophils dropping dramatically on our patients, and them feeling symptomatic relief. Endoscopic reversal of findings that are seen, the fibrosis status and whether that's improving, and then quality of life considerations, both with the disease and with the therapy we're offering the patient and to try to deal with the disease. Some of these slides are the older version. So I'll just kind of make some comments about this. So 1995, we have these kids with EoE. They respond to an elemental diet. We really didn't know how to treat this disease. First of all, most of us had a hard time believing it. I remember being in Boston, seeing this report. We've scoped thousands of kids at that point in my career, and never saw this. So we thought maybe there's something in the drinking water in Baltimore that was leading to this. And then slowly we started to see this. Our adult colleagues came on later because they really didn't do a lot of biopsies of the patients. They're looking for erosive esophagitis as a result of acid reflux. Now we kind of created some problems for ourselves because we always initially were dealing with is this an allergic response in the esophagus, or is this the result of really bad acid reflux? And there were early reports of patients with this profound eosinophilic infiltrates of their esophagus responding to acid suppressing therapy. That was taken to mean that you can really see really bad eosinophilic infiltration of the esophagus as a result of acid reflux. So we took on the position that if a patient comes in and they're having dysphagia or food is sticking, that we're going to put them on a PPI to try to eliminate acid reflux, scope them, and then see what the esophagus looks like. And if it's inflamed with eosinophils, they probably have this disease, EoE. Well, it took us about 15 years to recognize that there are a subset of patients with EoE that have a response to proton pump inhibitors. And it's not because of the acid suppressing effect of the proton pump inhibitor, but it's the result of the immune modulating effect of the proton pump inhibitor. So in patients with EoE, the reported numbers can be anywhere from 30 to 50% of patients have this responsive form of EoE to PPIs. And it's really because the PPI is downregulating eotaxin and some of the Th2 cytokines that are important in the inflammatory response in EoE. So now, instead of putting patients on proton pump inhibitors as part of the diagnostic phase of evaluating them, we're really kind of scoping them first, seeing if they have eosinophils, and putting them on proton pump inhibitors as a trial of therapy. Now, if they are responsive to PPIs, we have to think about what are the long-term complications. And I just put down here bone density for what we really consider to be our major concern in pediatrics. But in adults, when we're talking about long-term PPI therapy, you have to think about chronic kidney disease, dementia, C. diff infection, pneumonia, and so all of these things have to be discussed with patients when you're considering this is their therapeutic approach, particularly if it's going to be long-term. Now, in the early 2000s, the group in Boston looked at what would happen if we had patients swallow an asthma medicine, fluticasone, instead of inhaling it. And so Flovent was used in San Diego. The investigators there were trying Pulmicort and mixing it with something to make it sticky so it would kind of adhere to the esophagus. And then with both medications, the idea is swallow the medication, don't eat anything for 30 minutes, don't eat or drink, and let's see what the response rate is for those patients. And the response rate is really very good. Greater than 70% of patients will respond to this kind of topical, steroid treatment. Its long-term complications include oral or esophageal candidiasis. And of course, we're always concerned about bone density over the long term in patients who are on swallowed steroids, as well as adrenal insufficiency. So the group in Baltimore showed that elemental diets could work. What about other kinds of food elimination diets? Now, pediatricians have been doing this for decades and decades. Kids come in, they're pukey, they're colicky. We change the formula, they get better, they grow out of it. We think it's the formula, blah, blah. Well, I think here in Northwestern was one of the first groups that really tried to kind of look in some kind of rigorous way at eliminating foods and what the effect is on EoE. Now, around the country, other individuals, particularly among our allergy colleagues, we're looking at targeted food eliminations using skin testing and or patch testing, which is kind of a look at delayed type hypersensitivity responses as ways to try to identify the food that are the trigger for EoE. Now, if you look at the various diets that have been put out there, elemental diets work on a large number of patients, and probably the patient this is not working on have some kind of cross-reactivity or problems with aeroallergens as their primary triggers. The 6 food elimination, as I referred to, was really studied here at Lurie Children's, and it has a response rate of about 70%, but that means that 30% of patients have other foods or other allergens that are really responsible for their inflammatory response. And you can see that the response is about the same in pediatric populations as it is in adult populations. If you tailor that a little bit and bring it down to 4 foods, now I might say the 6 food really came up from what are the 6 most common foods that cause allergies in people. And it really comes to milk, dairy, wheat, soy, egg, fish, shellfish, nuts, and tree nuts. So those are 8 foods. If you can put together the fish and shellfish and the nuts and tree nuts, you come down to 6 foods. And that's what the 6 food elimination, that's where it kind of, it was born. If we take out and we say, just let's do the milk, dairy, the soy, the wheat, and the egg, what's the response rate to that? And it's pretty much the same in children as it is in the 6 food elimination. And it's probably because a lot of kids aren't eating a lot of shellfish and fish. It's not their primary source of nutrition. It doesn't work quite as well when studied in adult populations. 2 food eliminations really haven't been studied in children, but in adult populations, about 40 some odd percent, a little more than 40% are responsive to that food elimination. And if you take the 1 food elimination, just milk, dairy, about 40% of patients across ages will respond to that. These are just empiric. You know, these are trials. They require scopes. And then if you can identify responders within these elimination diets, the idea is to try to reintroduce foods, and there's a lot of scopes that are involved in that. Targeted food eliminations really have kind of fallen by the wayside because they're pretty much like flipping a coin. So when we sit down with a family, we're really having this shared, as mentioned, this shared decision-making process. You have to look at the age of the patient and their motivation, their stage in life, their living situation, their food preferences, their quality of life. Now, I've had 18-year-olds that have been willing to go on elemental diets and have done it for over a year. And I have 10-year-olds, if you try to take milk and dairy out of their diet, they break down in tears and they're having a meltdown. So you really have to understand the dynamics in a family before making these kinds of recommendations. The patients and the parents have to be understand the necessity of frequent endoscopies because it's really still the only way we have of assessing responsiveness. And that also includes additional cost and missing school and the travel that may go with that. So there's a lot of factors that have to be weighed in here. I think one of the most important things what we try to emphasize to families, though, no matter what our therapy might be for the child when they're 7 years old, it doesn't mean that they're on that for the rest of their life. And that's the first thing the parents think of. Oh, they're on a swallowed steroid. They're going to be on that for the rest of their lives. No, not necessarily. They may not be at 7 prepared to try a food elimination trial, but at age 15, they may be very willing to do that. So there are these things that are really important to have that discussion right up front, so people aren't leaving our clinics at least discouraged about what the future may hold. Now, the big thing out there now are biologic agents, and everybody is pretty much aware of the approval of dupilumab. So it's the first FDA approved drug, biologic agent for treating EoE in adults and children over the age of 12 and greater than 40 kilograms in weight. It's a very interesting situation that we've been using non-approved topical steroids, non-approved PPIs, and we have an approved drug that we have to actually convince insurance companies that they failed the unapproved drugs in order to get the approved drugs. So it kind of tells you how upside down the world can sometimes be. But this was approved. It's been on the market for eczema and for asthma for years now. It got approved for treating EoE in May of 2022. And it really is a very effective drug for both the symptoms and the, well, it has to be, in order to pass FDA muster, it has to be important, has to be first, improve the symptoms, and second, improve the histologic scores. Now, we also have a trail of failures. The anti-IL-5 drugs, resilizumab, there was no improvement of symptoms, even though we saw a marked reduction in the eosinophil counts in the esophagus. Metalizumab, again, it reduced eosinophil counts, but it had no symptom improvement. And then there's an anti-IL-5 receptor that has failed as well in some clinical trials. IL-13 agents, again, the QAX 57.6, it didn't reach its primary endpoint. There's another drug that's out in testing now that is RPC 4046, which has shown really significant improvement in eosinophil counts and in symptom scores. So I think that there's more to be said about that in future studies. Just for the sake of one of the questions that was in, and again, it didn't make it into this rendition of slides, but if you look at, because a lot of people are asking, what's the long-term effects of Dupixent? And I guess the jury is still out on that. But if you look at the short-term effects, what we see is allergic reactions. We see pain at the injection site. In pediatrics and maybe in adults, I don't know, we're also starting to see children having anxiety associated with the injection itself. There have been some ocular side effects, conjunctivitis, stomatitis, reactivation of herpes stomatitis has been reported in patients on Dupixent. And then there's the theoretical, you're kind of blocking an arm of the immune system that's very important in parasitic infections and what may happen if you travel to places that have high burdens of parasites within the environment. So I think that that's something that has to be taken into consideration. And it's also recommended that you're not getting live vaccines, measles, mumps, rubella, chickenpox. Those are live vaccines and should be avoided if you're on Dupixent. So what's missing here is a slide about all the other things that are in the hopper. And I'm sorry for that slide being left out, but we have a slew of other agents that are now under investigation. And I really think that if we were to look 10 years from now, the idea of using PPIs and swallowed steroids is probably going to fall by the wayside. And the primary therapy for patients would either be food elimination trials, potentially with investigations like Dr. Wechsler is doing we might be able to identify through various types of genetic studies and immunologic studies what the food triggers are in each individual, so we can individualize the treatment rather than empirically try trials. But it's going to be biologic agents and some of the selective inhibitors of the pathways that are involved in the inflammatory response in this disease.
Thank you, Dr. Wershil, for telling us all about the treatments. Just one question that I have for you, because it came up over and over and over again in the questions from the patients. If you could just touch on the long-term effects of steroids. Is that something that we've obviously seen it in occasional patients, and I will say we definitely monitor it. I think a lot of centers do, but would you say it's something that you would say is in general common to see side effects in patients on long-term steroids? And then I would ask the same of Dr. Gonsalves as well.
Disadvantage that, but our patients age out of our practices. And so when we're following these kids that are diagnosed at 6 or 10 or 12, and they're on topical steroids, we're only following for a short period of time. And so to the point, we don't see a lot of changes in their bone density. That's what we're really looking at. This is the prednisone where you're seeing all of the systemic side effects of medications like that. This is really about what's happening with bone density. So we follow their bone density scans, the DEXA scan, fairly regularly when topical steroids are the preferred therapeutic option. It's really just an off report from patient to patient, from center to center, to see kids that are falling off the mean of their age group on these medications. And oftentimes they have other kinds of conditions that are comorbidities and confounding issues. So just the normal healthy kid who has EoE, it's rare to see any issues with bone density over time.
I can comment just a little bit regarding steroid use, and we've learned a lot from asthma therapies through the years. So we've been able to study steroid use for asthma for chronic periods in kids, especially as young as 6 months, all the way to 18 years. So there's been a lot of studies with budesonide and also fluticasone that's been orally swallowed. So the stuff that we swallow orally gets into the GI tract and doesn't get absorbed systemically, in theory. But 1,000 micrograms of budesonide is equivalent to about 10 to 15 milligrams of oral prednisone. But we've done long-term studies in kids, and these children who've been on chronic inhaled steroids for asthma, believe it or not, their growth suppression is about a half an inch during the CAMP study. So we've studied these medications through years of pediatric asthma. But again, we're not studying it swallowed, but there is evidence of of adrenal suppression on patients on 1,000 milligrams of budesonide, or 880 of fluticasone through the day. So it's key to use the lowest effective dose to try to down titrate as much as you can. We put patients on Flovin 44 once they're stable. So I think the key thought here is to titrate down. And believe it or not, if you give steroids more frequently, you can actually get the same type of response as if you gave it, higher doses BID. So in theory, if you could give it more frequently, it would be better, but we just don't do it in EoE for some reason. But we've learned a lot from asthma through the years, and the parallels with asthma and the parallels with atopic dermatitis and treatments for steroids here are so characteristically alike. But they are safe for kids for, the duration wise. So I think you can be rest assured, but you should monitor for growth. You should monitor for bone density. You should monitor for adrenal suppression. So I think all those parameters when you come in for, the well visits, to make sure that you don't see any of these side effects.
All right, I think in the interest of time, what I'm going to do is have Dr. Kuang have your talk come after this panel session, and then we're going to go to Dr. Fortunato. And I think in the interest of time, I'm not going to actually give my talk today because I really want to hear from all the panel speakers, but you're all welcome to email me, of course, and I'll talk to you about mast cells and T cells all day long. So we're going to talk about Dupixent and other new treatments for eosinophilic esophagitis. And Dr. Wershil really touched on this actually in his remarks at the end. Because this is a big debate. I've heard everything from biologics for EoE are ridiculous to we need to actually start this maybe even as the first therapy. And so I really want our panel to jump in on this question and try to help me understand, should dupilumab be first or second line after acid medication? Because I think we generally all agree that that's a very affordable over-the-counter therapy that makes a lot of sense and generally low risk, at least if we're able to dose it pretty low.
So we were all just at the digestive disease this week, which is one of the largest GI meetings in the country. And there are a lot of pharmaceutical companies that come and present their wares there. So I went to the site of the companies that produces Dupixent, the Sandifer Regeneron, and I asked them, "What's this stuff cost?" And they kind of balked and they hummed and hawed. I said, "Come on, how much does it cost?" And he goes, "Well, probably about $3,000, a month." Which is really good compared to other biologics. So there's the rub. No matter how good a medication is going to be, if most people aren't going to be able to pay that out of pocket, and a lot of insurance companies are going to push back to using it. So, the practical approach to this would be everybody should be on Dupixent, because it's a once a week and you can eat everything other than your anaphylactic food issues. So, and then you can do anything from there. And most of that anything would be food eliminations to try to not be on a medication. But that's just not the real world. And it probably won't be the real world for quite some time. But I think that when you look at quality of life, take even the idea of taking the topical steroid twice a day, it's great if your mom can mix up the Pulmicort, but kids aren't going to stop in college to mix that up, or they'll forget about it. You can carry around the fluticasone, but it's really easy to forget that as well. So it becomes one of those things, but if a once a week injection, I think is much more manageable, and it allows the freedom of all food choices. That being said, anybody who's in my office, the first thing I'm going to talk about is food elimination.
Me too.
Because there's no medicines. And if you can identify those triggers, you can go off and have some real choice in your own lifestyle. So I think that's really where it exists right now.
Okay, my turn. I actually agree with a lot of what Dr. Wershil said. I mean, I think at the end of the day, it really comes down to the individual patient and what's important for them and their goals of care. So we have a very candid discussion about that. We talk about the pros and cons of all the treatment options, and some people would much rather be on a medication, not do dietary therapy. Some people are very medication averse and would rather do dietary therapy up front. And then, of course, there's the practicality of being able to use a once a week medication to control all of this. I mean, at DDW, there were a lot of talks about this, and Dr. Dallin did a lovely talk about biologics, and exactly this question came up: where do we position dupilumab? Do we position it first line? Do we position position it farther down. And, I think practically speaking, it's similar to what Dr. Wershil said. It's probably going to be positioned a little bit farther down and trying some other treatments first. A lot of that is coming down from insurance companies and a little bit of pushback, which is a little ironic. But in terms of coming back to that individual patient and someone who may be on a lot of other topical corticosteroids, who are taking topical ointment for their skin conditions, who have all these atopic conditions and food allergies, that may be the perfect medication for them up front. So it all really is a very individual decision, I think.
Okay, Natalie, I'm gonna have you answer the next question, which is, are there specific situations where Dupixent makes more sense? So it's now the preferred choice in that situation.
Sure. I think we mentioned a couple of them. So in terms of using it with patients where food elimination may be difficult, there's growth concerns, there's already a lot of food allergies, it's just not going to fit into that patient's quality of life, would consider it more highly. In addition, if patients are already on inhaled steroids for asthma, and they're a bit more risk of some of the side effects, if we go to a topical steroid, we would consider it. And certainly in patients that don't want to take a daily medication, that may be a better option. I think the jury is still out a little bit on if patients with a more fibrotic phenotype or who are more prone to developing scar tissue would respond better to certain targeted therapies like Dupixent. But I think soon we'll have a lot more information if that's the case. And in that case, we're making more of a tailored treatment decision based on the patient's individual disease.
Okay, and then my last question for the panel is, can Dupixent be given with other biologics? And do we know the answer to that one? I mean, I've had a few patients that come in on anti-TNF agents, but they also have bad EoE, and I can't control it with swallowed steroids or diet. Is it reasonable for them to have two biologics at the same time? I don't think we have a lot of experience with this, and I'm curious, what the panel thinks in this regard.
So to me, I think that it's a question of what the other biologic is and what are the risks associated with that. So if the patient's on something that blocks a part of the immune system that helps them fight infections, like TNF alpha blockers, I'm not sure I completely understand at this point if we really know the immunological infectious risks of Dupixent. When we've been co-prescribing medications like TNF alpha blockers and anti-IL-5, for example, or Xolair, which is anti-IgE, those two other ones don't carry an increased infectious risk. And I think there's a lot of community experience using both and hoping the insurance companies won't get upset about it because patients actually have legitimate reasons to have both. So I'm comfortable anecdotally to do that. But I think that the jury is still out about Dupixent, in my opinion on it. Do it differently in kids.
No, similar in like pediatric population, we don't always get two biologics approved. We're lucky to get one approved. But, again, if the child has got atopic dermatitis, who's got another atopic like, asthma, as you mentioned, Dr. Hoffmann, we probably consider Dupixent in that group. And sometimes, I've like backdoored Dupixent in for the eczema to treat the EoE and the asthma in the past. So that's what we've had to do. We've had to say that the asthma is bad. So therefore we're able to treat the eczema and so forth. But now we have the eczema diagnosis all the way down to 6 months, which is great. So I wonder if we're going to change the disease trajectory and the biological therapies, because with asthma, again, the parallels that we had with asthma and EoE, if we didn't have steroids in the past and we're able to use biologics earlier, could we change the disease trajectory? I think we can. Problem is that, we need to start early enough in these atopic kids. And if we get them early enough and control their eczema and control their other inflammatory conditions, maybe we can make a difference to that. So, Dupixent along with that, but it's rare to get two approved in pediatric populations.
I think Dr. Hoffmann and Dr. Nimmagadda raise a very interesting point about whether or not we're going to be able to change the natural history of EoE. And in phase 2 trial data, the stretchiness, the distensibility of the esophagus improved on this drug. My question though, for our panelists is, how often, or do you have patients where they actually are going to have to stay off food, be on a swallowed steroid, or remain on acid suppression with PPIs to be able to control the EoE effectively, where they had a partial effect from dupilumab? I think I've seen this in a small number of patients already.
So just to clarify your question, Josh, you mean how often are we seeing a suboptimal improvement on Dupixent because they have had to be on multiple therapies?
Yeah, I think this raises the question, of course, about the eosinophil being the perfect measure of disease, right? And that, you know, at the end of the day, we have our symptoms, which might be better, but not fully resolved. That could be, of course, due to scar tissue. There might have been 80% improvement in the way the esophagus appears, yet a little remnant of inflammation that exists. That's technically not remission, you know, and then at the end of the day, are we putting patients on dual therapies then in order to address that? Thank you for asking for the clarification.
Yes, I mean, I think that's definitely something that we are seeing. While it would be nice to have one therapy that's going to be the perfect therapy that's going to result in 100% effectiveness, that's just not the case. And we are definitely seeing patients who are on these biologics who are not achieving that effect. And that could be because ultimately a PPI was helping their reflux and they did have silent reflux, or their foods are still driving that response, or environmental triggers are driving this response. So yes, there are people who are not achieving that effect.
Yeah, I just want to like double down on that a little bit. You know, we tend to think, you know, these linear thoughts that you either have EoE or you have reflux, and there's no reason you can't have both. And I think that we lose track of that sometimes in these in the way that we're approaching patients, that there are some patients that have, you know, dual conditions and we're treating one but not the other. And if we could, if we attack both, they're going to have clinical and histologic improvement.
Yeah, I absolutely agree with that thought process. And the idea that you have a partial responder to something oftentimes gets lost, that you're either a responder or a non-responder. I think there's a lot in the middle. All right, we are going to move forward to Dr. Kuang's talk, the role or roles of an allergist in managing patients with eosinophilic esophagitis.
Okay. Thank you, everyone, for still being here. I know it's late. I, too, will try to keep this to, I think, the original allotted 10 minutes. So my name is Fei Kuang. I'm an allergist, adult allergist at Northwestern. Most of my clinical practice is patients with eosinophilic disorders. An increasing chunk of it are kids who've graduated out of being a pediatric patient to adults who are now dealing with, well, what am I going to do now that I'm in college, or, you know, I'm going to have kids soon or whatever. And so I have a particular interest in taking care of those patients, as well as a research interest in the area. This is, do I mouse?
Should be like just
Click where?
just on the screen.
I did. Oh, here we go. All right. So 4 reasons how 4 ways an allergist can help a patient with EoE. So this talk was really intended for people who may have a new diagnosis. I know probably many people in the audience know what a food allergy is or very familiar with allergists, but this is intended to bring everybody kind of like up to the same speed, I hope. So the first thing is an allergist can help diagnose and manage other allergic conditions, which we've heard alluded to. An allergist can help figure out if an adverse food reaction someone is having is actually a food allergy, the kind you need an EpiPen for. Sometimes in parts of this country, an allergist is the primary person managing EoE. And then the last one, which has become part of what I do more of now, is identifying patients who need help with reintroducing foods that they may have avoided for a long time or all their life because of EoE. So if you've never been to an allergist before, this, I think what some of my patients who are new come into my office thinking, what happens when I come to see an allergist? I have this crystal ball, we plug in some allergy tests, and boom, we have answers to what I'm allergic to now, what I'm allergic to in the future. And I think you in the audience who've ever seen an allergist know it doesn't quite work like that. We ask you a lot of questions. Did you eat this? Was there butter on it? Was there a dog nearby? What do you have on your floor? Is it carpet? Is it hardwood? And then taking all that information together, we design and create a list of some specific allergy tests or breathing tests if we're diagnosing asthma to perform. So it's not a comprehensive panel that everybody gets the same thing, but it's based on the history and what is happening with that person. So the first thing, other allergic or atopic conditions that we might diagnose or manage. Many EoE patients have at least one other allergic condition, and that might not rise to the forefront of a parent or a caregiver's mind when they're just handed this new diagnosis. And this includes asthma, food allergies, environmental allergies, and eczema. Treatment of these other conditions, we hope, improves the quality of life for those conditions. And in some of them may improve their EoE due to some shared disease pathway. And we kind of alluded to that as some drugs can actually treat multiple diseases. But it's important to have that diagnosis if you want to make use of that part. I think the other important thing to know is that there have been several studies over the years showing that there's a seasonal variation in both the rates of EoE diagnosis and flares of disease. For example, during high versus low pollen season in those patients who have environmental allergies. And this is seen in pediatrics and to some extent in adults. And so I recommend to my adult patients that even if they're not super, really, really bothered, or they don't care that much about their allergic rhinitis, to please treat that with their nasal steroid sprays or getting the dog out of the bedroom, what have you, especially before they have an endoscopy. And that's because you don't want that little bit of extra eosinophils that could be in your esophagus due to your allergic rhinitis, then lead you to say, this food is a food trigger, because that would not be a good, outcome. The second point is my adverse food reaction a real food allergy, like the kind I need an EpiPen for? And we kind of talked about it a little bit earlier. Can current food allergy testing identify EoE food triggers? This idea of like, do I have a crystal ball to help identify what I'm allergic to or what I have EoE, eosinophilic inflammation to? So for those who've never had a food allergy or met an allergist, food allergy diagnosis is combined of two things: the right story. So lots of questions. What did you eat? When did you eat it? What happens when you eat it multiple times? Does this happen when you don't eat it? And then select allergy tests to particular foods. And a very severe allergic reaction we call anaphylaxis is usually immediate. Very severe can involve respiratory, low blood pressure. And so patients with true food allergies are usually prescribed and should carry EpiPens, which are emergency injection medicines. So what does an allergy test look like? So there's two kinds. One is a skin test. You get little droplets of whatever it is that we're testing you to on the skin. And it's a little like toothpick kind of prick through that little droplet of liquid. And you wait 30 minutes for an itchy mosquito bump thing to show up on your arm. And that would be positive, and they measure it. The alternative is a food allergy blood test, and that measures IgE. IgE is an immune system protein we make. They're antibodies, but they're usually thought to be, we think, used to be for fighting parasites, but in our world, we have it to fight allergens for no reason. And if you see on your blood tests, it might say RAST or immunocap, and then more advanced ones are component testing for certain foods. I think if I could have you take home one message from my talk today, is to avoid broad food allergy panels, which are tests that say, like, we're going to measure 30 foods, IgEs, in patients who don't have actual reactions to all of those 30 foods. Because unfortunately, people come away and they come see us afterwards as adults or as a second opinion with lots of false positives. Dr. Wershil talked about this a little bit earlier, but current food allergy tests do not reliably identify food triggers in EoE. And the bottom line is more research is needed to identify non-invasive ways of identifying those. So just a little bit of history. 20 years ago, there was this first report that food allergy test, the skin prick test that I show you, and there's something called a patch test, which they smear some food on your back and you wait a couple of days to see a skin reaction, that this combination of tests could identify EoE food triggers. Then there was lots of little studies over years, and I highlight two of them, one actually by Dr. Gonsalves, who you heard from earlier, where they, in the course of examining 6 food elimination diets and reintroducing specific trigger foods. So they're doing endoscopies to show and prove, okay, this is a food trigger, this is not. Alongside that, food allergy tests were done. And what they learned was that 13% of the time, the skin prick test actually identified the correct food trigger, and that more than half the patients had negative skin prick tests to all the foods that were being eliminated or reintroduced. So that's not a very good track record, right? Patch testing, also called APT testing, that's even worse. So this study I happen to pick is from Mayo Clinic. It was able to identify the food trigger in 6% of these EoE patients. That's just 2. So in 2022, there was a systematic review. And so that's when people searched the literature for all the studies that examine this question. And they have some criteria, like we want studies that are this kind of quality that, actually track people's responses and so forth. So they have a bunch of criteria that they consider high quality. And amongst these 20 years of small studies, larger studies, there were 16 that met this criteria. And in the end, they concluded that targeted elimination diets, so by choosing foods based on allergy, skin testing, skin prick, patch tests, or blood tests, do not appear superior to empirical elimination diets, which you saw in that table that Dr. Wershil showed earlier. The third point, sometimes it's the allergist who takes care of the EoE. We're lucky here that we have allergists and gastroenterologists that are very familiar with this disease, and many of whom are at this table were there when this was described and have been along for all the trials. But that might not be the case in the part of the world or part of the country or state that you live in. And sometimes it's the allergist who directs the care. And so I've seen, and it's not abnormal for the allergist to direct the care, but obviously there's always a collaboration with the gastroenterologist. I'm showing you here the practice parameters from both our allergy colleagues, our allergists, our allergy journal, as well as a gastroenterology journal, which is a combined set of clinical practice parameters that was produced by both subspecialties together. And the last thing I wanted to talk about was safe food reintroduction. So I see adults, some of them have carried this, I'm allergic to this for many, many years, but I don't know. Or I've had an abnormal allergy test 20 years ago, but I don't know. And now I'm on Dupixent. Can I eat X food? And so, what do we do about that, right? So there are rare case reports of patients who develop immediate food reactions that could be anaphylaxis after long periods of avoidance. How often this will occur, we don't know. We're at the front of discovering this knowledge. Sometimes, as I said, there's a history of very positive food allergy tests or skin tests done a long time ago, and people don't remember. I was 2. I have no idea what happened when I was 2. And so an allergist can be helpful in trying to figure out that history with you, and if appropriate, performing allergy testing. And then ultimately, if that food is important and we decide importance in conjunction with the patient, perhaps with the registered dietitian who helps helps the patient decide what food group do I need next. This is the food group we should try to reintroduce, or this specific food. Then a patient, if it seems appropriate, can be scheduled for an oral food challenge in our clinic. And that's actually the gold standard for a diagnosis of food allergy. Can I eat this food and be fine, right? That's no matter what the blood tests say, no matter what the skin tests say, if I eat this food and I can be fine, I don't have an anaphylactic reaction to that food. And so in an oral food challenge, the person brings in the food, they would be gradually given tiny amounts and larger amounts of it until it's a full serving, and they're monitored for symptoms, usually for at least an hour after the full dose. If you're coming to have a food challenge with me, I'm not going to have you do it in my office unless I think there's a good chance that you might have a reaction or you're too scared to do it at home. And so in that case, when you do it in my office, we have to be sure that we are all comfortable handling anaphylaxis, which we are, because we give allergy shots all the time where people can have anaphylaxis in our clinic. So I think that sums up what I wanted to say. And those were the first 4 things I mentioned. And I add a 5th thing in the end: how can an allergist help a patient with EoE, which is in collaborating in clinical and laboratory research on patients with EoE. So I, as a last plug, I do research in this. Most of my time I work in a research lab and I do research on patients. But wherever you are in the country or in the state and you're listening in, if there's an opportunity for you to participate, know that that will contribute to the next generation of patients who have this condition, because what we know today came from the patients who participated 10, 20, 15 years ago. And that's all I have.
Thank you so much, Dr. Kuang. I couldn't agree more. I'm so thankful for all of the participants and all of our research at Lurie, and I'm sure Dr. Gonsalves would say the same for the program at Northwestern as well. Well, with that, we are going to turn to our final speaker regarding a topic that I got interested in probably in about 2019 or so, realizing that there were definitely more to my patients than just the EoE, and seeing a lot of patients that had hypermobility and POTS, and really beginning to wonder what's going on with these patients. Well, we are lucky at Lurie to have a world-class expert in these conditions and the interaction with the GI tract, Dr. John Fortunato, to talk to us about the growing roles of EDS and orthostatic intolerance in pediatric gastroenterology.
Thank you. Well, now for something completely different. Let's see. So I'm going to purposely cherry pick through some of our slides just in the interest of time. So I was tasked to look at how we screen for Ehlers-Danlos and joint hypermobility, as well as orthostatic symptoms. People may have heard of the condition POTS, post-orthostatic tachycardia syndrome, and the associated conditions and treatments. That's my charge. That being the case, how do I relate this to eosinophilic GI disorders? I hope to convince you of that, but if I don't, it'll be over in 10 minutes, so we'll get through this. So I think it's kind of important to actually establish some definitions in terms of Ehlers-Danlos, in terms of what is hypermobility, and really kind of from a higher level, what the impact is of connective tissue disorders in the GI tract. So I do want to talk about this, but I want to kind of connect this triad, if you will, between GI symptoms, joint hypermobility and connective tissue issues, and this orthostatic intolerance. And I use that term because I think it really is more descriptive and more accurate, meaning orthostatic, standing up, and intolerance and dizziness or lightheadedness. And again, the chicken and the egg is really sort of the big question that we ask for conditions like this. So just to give some sense of what Ehlers-Danlos is this group of connective tissue disorders. It is a huge spectrum of presentations, but by and large, it falls under the category of hypermobility spectrum disorders. And if you look at some of the pictures here, some of the characteristics that we see with the disorder itself, flexibility of the skin, the hypermobility of the joints, ecchymosis or bruising. These are some of the typical things we see really for established Ehlers-Danlos. That doesn't preclude the idea that actually there are a fair number of patients who don't have all these symptoms, who do have connective tissue issues, who can manifest even primarily as a GI problem. I'm going to pass through this, but the purpose of this is there are some genetic links to these phenotypes, but not every single patient with hypermobility syndrome has a genetic connection. And not to breeze through it, but there are very simple things we can do in our clinic to actually look for these issues. This is something called a Beighton scoring system. It's really a 9-point system that looks at hyperflexion or extension of the pinky finger, the thumb, knees, elbows. It takes about 3 minutes to do in a clinic. And again, it's something that's very non-invasive that can, again, put that parameter of hypermobility in context. And I think just as we kind of go through this, my purpose in saying this is if there's anything I can link to eosinophilic disorders is the whole notion that we're all about comorbidities and how the circles in the Venn diagram actually intersect. So it would be nice if one patient has a swallowing issue, EoE, done. Well, most of those patients have other coexisting symptoms, and sometimes one issue or one mechanism can affect the other. So just to start with sort of the GI tract and how this actually impacts motility. So this is just some examples of really hyperdilated intestine, in this case, the colon. And so really the notion of the GI tract being involved with Ehlers-Danlos has been established since the late 1960s by actually Dr. Beighton. And so you see in some of these images here, a very long colon, almost like an apron coming from the hepatic flexure down and back to the splenic flexure, a dilated colon. In adults, we actually see more evidence of diverticular disease, again, from this connective tissue weakness in the GI tract. So again, this is just one example of connective tissue issues translating into anatomically deranged, if you will, parts of the GI tract, and actually consequences in terms of movement. And I am going to try to connect this very briefly to EoE. So it has been actually shown that in a cohort of patients with eosinophilic esophagitis, they can actually have features of connective tissue disorders, including Ehlers-Danlos. Now, again, it's way beyond the scope of what I want to talk about tonight to say, oh, we found the magic gene. Clearly, nothing is that simple. But the fact that there's a connection between EoE, connective tissue issues, and even some genes that may help to define this overlapping phenotype, it just kind of begs the question of why. Why is this an issue? And again, the easy answer is we don't know. But if you think about it for a moment, with connective tissue issues, just from the picture you saw previously of a dilated colon, well, do these issues affect the esophagus, the stomach, the rest of the GI tract? Well, clearly they do. Now, does that have an impact in terms of transit through the esophagus, both up and down, both in terms of clearance from reflux, exposure to allergens during actual consumption, during actual swallowing? Again, it's an easy answer. I don't know. But certainly when you start to bring in these variables together in terms of potential motility disturbances because of a connective tissue issue and the immunologic and inflammatory issue, is there some overlap in terms of that chicken and the egg? And so it's food for thought, but I did have to say something eosinophilic related as the motility person. So to kind of look at other mechanisms that I think are relevant, we talked a little bit about how the GI tract, being a smooth muscle and connective tissue, actually is subject to injury just from dilatation when the connective tissue is not working the way it should. But there are other parts of not just the GI tract, but the body that can be affected as well, including the musculoskeletal system. You know, patients who actually have defecation disorders, who have pelvic floor issues. And this is just some example of abnormalities and prolapse, if you will, because of those supporting structures. But again, getting back to what my task was here, was to talk about the Ehlers-Danlos POTS-OI patient population. So I just want to take a moment to talk about another type of part of the body that actually has a fair amount of connective tissue, and that's the blood vessels. And that's where, when we start to kind of put these pieces together, we think, okay, was there an issue not just with the GI tract being dilated, being stretched because of connective tissues, but the vasculature? And this kind of is maybe sort of the segue, if you will, into the orthostatic POTS patient population. And I'm just going to bypass that for a moment. So the purpose of this is really to kind of connect the dots. It's this trifecta of looking at GI symptoms, whether they're functional in nature, as it relates to the connective tissue, joint hypermobility patients, and orthostatic intolerance. And it would be nice if this was a linear graph, but clearly this combination of pathology is not. It's three-dimensional chess, not, I don't know, two-dimensional chess. There is such a thing. And I'm going to bypass some of this for just a moment, but for the purpose of some of these slides was, again, to look at, we see this connection between connective tissue issues and orthostatic dizziness. Again, when you look at patients who have benign joint hypermobility and functional disorders like chronic nausea, like swallowing issues and abdominal pain, yeah, there's certainly an overlap in terms of both these patients having autonomic related issues. And I'm going to leave it at that because, again, I say autonomic related issues, but not dysautonomia per se. Again, cause versus consequence. And this is just another example of that. Looking at patients with joint hypermobility, a fair number of these patients, meaning somewhere in the vicinity of almost 80%, have some evidence of orthostatic dizziness. So again, it seems like a little more than a coincidence when we start to kind of dissect this further. And so, again, trying to connect this to the functional disorders and orthostatic intolerance, same type of thing. We see patients with a high prevalence of joint hypermobility, high incidence of POTS, orthostatic intolerance, but again, not necessarily a direct correlation between the hypermobility and the POTS itself. So this is kind of the fun part of what I do, is trying to bring this together in terms of how do you explain this chicken and egg and mechanistically pull it together. And this is the work of some of my colleagues, both at Mayo Clinic and out in at NYU. And one of the things that was interesting, it was when they looked at patients with orthostatic intolerance, reported or demonstrable POTS versus controls, they actually did see differences in blood flow in these patients. And again, we start to kind of link these things together. What is actually the underlying root cause of POTS? Again, to be clear, we don't know, but the notion of splanchnic pooling in the blood vessels are bigger capacitors. Dr. Hoffmann talked about a more stretchy esophagus. Well, these blood vessels in these veins are actually, in fact, more stretchy. Basically, they have a higher capacity as a result. And so effectively speaking, when you're hyperstretchable and the tank is hyper full, it's almost like being dehydrated when you're not in a lot of ways. And so effectively speaking, you're pooling the blood where it doesn't necessarily belong and not pumping the blood where it would be more effective. And that includes the GI tract. And just to kind of put some numbers to it, this is an oldie but a goodie. This was actually my grad student years ago. And one of the things we had actually looked at doing was to see what kind of impact, were there tangible objective measures that actually helped to support this. And one of the things we found that in a lot of these patients we saw with functional nausea and orthostatic intolerance that we actually tested on tilt table testing, lower blood pressures were associated with higher levels of catecholamines, such as epinephrine, norepinephrine. The one thing that was really interesting was a particular transmitter called a vasopressin. And the thought was, well, this is not necessarily the root cause, but potentially a consequence. And so when you start to think about this now, you think about connective tissue issues, you think about dizziness, you think about GI issues, anatomic issues, all these variables in the equation, and it's a morass of data. But again, the only way to really effectively see these is to look at a high level at these symptoms and not develop this kind of siloed unifocus on just one particular symptom. So the reason this is important, and this is one of my colleagues at Johns Hopkins, it's just interesting when we look at patients, whether it's with functional GI disorders or symptoms, by and large, it takes a long time to get to the bottom of things. And so the reason this is important, whether it's eosinophilic directed inflammation in the esophagus or other orthostatic symptoms, it takes sometimes 1 to 2 years before these symptoms are accurately, I would say, synthesized, analyzed, and actually definitive diagnoses are actually put together with focused treatment plans. So it has an impact in terms of quality of life, and it has an impact in terms of functionality. And if you think about it for a minute, in our patient population, the sicker you are, the sicker you become. The sicker you become, the less that you do, the more deconditioned you become. It becomes a snowball effect in terms of the downstream consequence. So the point is, again, know your patients. And I think if this could be my punchline, it's impossible to know a direct causal mechanism. It's impossible to know the genetic correlation, if you will, to phenotypes without knowing the phenotypes. And so one of the things that we advocate for in our program is really trying to objectively define symptoms using a cascade of hopefully well-chosen questionnaires. And I'm not going to get into detail, but the fact is we screen for conditions like orthostatic intolerance. We look at the joints. We look at actually the impact of chronic anxiety as it relates to GI symptoms. I mean, the notion of an anxious child being dizzy is not going to blow anyone's mind. But again, looking at that and putting that into context, I think is really how we define the phenotype and actually objectively put numbers to the symptoms. Now, our group is actually working in partnership actually with the Kellogg Business School to actually develop more digital-based platforms to be able to, number one, more effectively collect this information, to disseminate it to clinicians in a more user-friendly way. Because the one thing that patients really, really don't like to do, especially teenagers, is to get 40 pages of questionnaires to do. In fact, the verbiage that I've been told is obviously too offensive to say at 8 o'clock at night on a weekday. But needless to say, again, what it underscores is know your patient population. And so if we develop platforms that can actually pull the data in an effective way where adherence is high, we get more data, we understand potential mechanisms. So to conclude, I'm sure I'm over my 10 minutes. So my charge, how do we screen? Well, you got to ask the right questions. You got to look sort of outside the spectrum of the primary symptom, including looking at comorbidities. In order to connect all the dots, you got to have the dots to begin with. So use the tools to be able to screen. And sometimes the screening tools will actually eliminate a particular origin or particular causality. How do we treat? by and large, treating functional GI disorders as they relate to orthostatic intolerance and connective tissue issues. There's not a pill for it. There's unfortunately not a biologic agent or anything to that effect. So in a lot of ways, we assess the symptoms and we treat on a symptomatic basis and we reassess. And I'll leave with that for a moment. And I think the big message is, yeah, it's a team sport, team science. So we really do take this integrative approach versus a siloed, funnel vision, because tunnel vision to this, because otherwise you miss things if you get over-focused. And so I stole this from one of my colleagues years ago, so I like it with the elephants. So yeah, it's all about the multidisciplinary interaction among disciplines. And I will stop there.
Okay, thank you so much, Dr. Fortunato. I completely agree. If you don't ask, you will never figure it out. I've been shocked at how many times I'm the person diagnosing Ehlers-Danlos or POTS for the first time, but it definitely occurs. I really wanted to thank all of our panelists today, Dr. Wershil, Dr. Gonsalves, Dr. Hoffmann, Dr. Fortunato, Dr. Kuang, Dr. Nimmagadda, really for Bethany Doerfler, Sally Schwartz online, for really contributing very significantly to helping everyone out in the community to understand core elements of what is absolutely necessary to diagnose this disease and to effectively treat this disease and take care of yourself in the end. I'm really appreciative for everyone sticking around to the end here. I'm really sorry I didn't get to give my talk, but I think that that's a prelude, hopefully, to our next session that we will find time for when I'm happy to tell you all about mast cells and T cells at that point. But in the interest of time, I really wanted to say thank you to everybody once again for participating and for joining us.